case presentation. And today I'm so glad to be able to introduce the team from Mount Desert Island Hospital. So we have Philip Pizzola, Director of Medical Imaging, and we have Kimberly Yo, the Supervisor for X-ray and CT scan as well. So I'm going to turn this over to them to do our case presentation today. And thank you so much.
Okay, so this kind of fits in perfectly with what we were just talking about, and I think some of the things were answered. Kind of what I'm hoping to get out of this is maybe a smaller hospital that doesn't have dedicated staff to this. You know, we just have the CT techs that kind of take care of all of it. And so at that point, who's responsible for following up with the patient, you know, to remind them if they do have 3-month, 6-month follow-up, and the provider too, to let them know, you know, to make sure that they're getting those results, and if they're the ones that should be telling the patient, making sure that they do that, and how that works without a staff dedicated to it.
Great. So basically, just in regards to results and follow-up is your question, right? What you're looking to get back from the group.
Yeah, if somebody has probably more positive result and does need that follow-up, how is that being translated to the patient and the provider?
Great. Do you want to give a little background on what you folks do now with that, just so people can see if it's similar?
Sure. So what we do, like I said, it's just the CT techs that take care of it. So we just kind of have an Excel spreadsheet of the patients that are done, what their results are, and if it's a negative, we send a lay letter, much like we do in Mammo. If it's positive, it's a follow-up program that isn't just the CT techs, it's kind of our whole medical imaging that, you know, we go through, make sure that the patient was followed up with the doctor. If not, we do send a fax to the doctor saying, like, just to make sure that they got those results. And we do that twice, and then if there's no more, we don't have any more follow-up after that.
Phil and Kim, can you hear us?
Yes.
Oh, there we go. Perfect. You're back. All right. No, we couldn't hear you before. Philip, were you saying something before?
No, he just had to step out for a minute.
Okay. All right, great. Yep. No, for some reason we lost the connection, but nope, you're back. Clear as a bell. Perfect.
Okay.
Okay, great. No, thank you. So yeah, so that's how you folks do it. So again, just wrapping this background that you're really looking to have people share what they do around this process.
Yes.
Perfect. All right, so just putting this out to clarifying questions. And again, we're just doing the question part now before we do recommendations. So does anyone have any specific questions for Philip and Kim around their process or what they're looking for today? And again, *6 if you're on the phone and lower left to unclick to speak. Excellent. I think everyone's really clear, Kim, on what you're asking, so that's great. And so I'm going to turn it over now to faculty to see if they have any specific questions for you as well. Faculty? So while we're waiting for them to unmute, one question I had for you, Kim. So you had said that you have the follow-up program that you follow. It's your whole, department, and you send 2 reminders to the PCP. And is there a way that they communicate back to you that they have received that information from you?
Yeah, so on the sheet that we fax them, it either says, yes, I followed up with a patient, and they have a follow-up scheduled. I've talked to the patient, they don't want to follow up, or I don't think that this needs to be followed up, which probably wouldn't be the case for a lung cancer screening. But there are.
Right. All right, perfect. So there's definitely this bi-directional communication then that you have set up with them. Great. Okay. Anyone else have any other questions? All right, at this point, we're going to roll into I know that Barbara, you've touched on a little bit. I know our More Than Light team has touched on a little bit. We can go into a little more detail at the end for faculty. So just reaching out to all of you now, as folks on our Echo, if you could unmute and just maybe share a little bit about how you do it and your organization does it, that would be incredibly helpful. And per usual, we'll give everybody a chance to do that. And then once everyone's had a chance to volunteer to do that, we'll do like we usually do, and I'll just go around and ask people if they can share. So again, feel free to unmute.
Hello, at Mlcc, we are in flux with changing our system, but we currently have a PA in radiology who sees the patients after their exam, and we've been not just wording that in a way, Andrea tells me of, wait here and then you can get your exam results. So we do have a person that's dedicated to helping out with that right away. But as a nurse navigator, I will be putting in provisional orders for follow-up exams for the PCPs. And we've spoken with the PCP group that happened right after our last echo, and they are okay with that. So that will help kind of keep the patients in the system that are already in the system. And we've been working to raise the PCP awareness so they order the test initially first and help the patient population that way.
Great, thank you. Quick question. So when you say the PA meets with them, so there's someone there that is able to read the scan right away and then be able to get those results to the PA? Great. And then do you folks track those results? So looping back around, right, with their questions and how to follow that, that was what Kim was asking. So do you track those and then send reminders to the PCP, or how does that kind of follow up work?
We track those results, and then currently we've been calling the PCP office to recommend the follow-up, but the process will change so that I will go ahead and enter the order for the follow-up, and so they'll be aware of it because of getting their queue in Cerner to co-sign the order, and anything that is concerning, they would still be getting a call if it were a 6-month follow-up rather than a annual.
Great, so just to be clear, as I'm writing notes too, so, and this is based off some of that meeting, which is pretty awesome that that has kind of rolled into this. So instead of sending that communication, the expectation is that you have an abnormal scan that's come back, and so you're putting the order right in for them, that goes right to them, and now they're gonna be expecting that and knowing that. And so that's that new component that you were talking about. So they'll order that, and so they'll sign off, and that will be done. And then again, will you relay those results back to them? So this circle of communication, you know what I mean? How's that work? Or do the results go right to them? How's that work?
The results would go to them, and I also get them from our administrative assistant who does the lung registry entry each month. So it comes comes back in a couple of different ways.
Oh, I like that idea. I like the idea of using the lung registry as well.
It just helps cue you, and then you just have that second chance to look at the patients again.
And does the information, how's the information get to your administrative person that does the registry? Does that come from you folks? How do they get that information to enter?
So the CT techs that fill out kind of the low dose form prior to the scan, they go over with the patient. What I do is I scan that in, and I have a file on what we call the W drive that the administrative assistant has access to. So everything gets put in that folder, and she has access to it. We have access to it.
Great. And then you'll do the same thing and upload. So in other words, when you do that, you're uploading the results. Is that what you're saying to do in there, or just the order itself, and then you follow up with the results?
The results are uploaded onto a spreadsheet, and that work is done by our administrative assistant.
Okay. So she fills out the spreadsheet, and she also updates the registry.
Yes.
Perfect.
Yes. And so monthly, she'll send me her copy of the spreadsheet. And so we take a look at that, but now that will become a double check because I would have gotten communication through Cerner from the radiologist anytime we have a concerning lung rad. So I get that the day that happens.
You get that right from the radiologist to you if you have a concerning lung rad.
Yes, and I misspoke. It's from our ACPA system that I get that cue about lung rads that are concerning and need follow-up.
And then again, that loops back into, you'll now put in the order, right? And then the PCP will approve that. And then you'll help track. Yep. Okay, great. Great. Thank you so much.
You're welcome.
All right, anyone else have any other ways that they track this and do this that they'd like to share? I know we are missing a couple people today. We have some people on vacation and they weren't able to join us, so I do want to recognize that. We have our full consortium that we usually have today. Anyone that's on the phone that would like to unmute as well and kind of talk about how they do things?
Jessica, this is Neil again. I have one more clarifying question, just so you know. I'm willing to wait while people offer suggestions if there are any.
Sure. Yeah, we'll give a minute and then absolutely. Why don't you ask that question and then we can move over to faculty and for their recommendations. So sure. Does anyone else have any other ways that they do this that they'd like to share? And what we can also do too, just be aware, Kim and Philip, for those that aren't here, I think it makes sense to, I'm happy to follow up with them and then kind of get their process back to you as well. Because I know that will be really helpful.
Yeah, that'd be great. Thank you.
Absolutely. Because again, and some of those are that smaller hospital piece too that you were looking for. So I'm happy to follow up with that and again, get those results, how they do that back to you. Great. Okay, Neil, if you want to go ahead and ask your question.
So one of the things I heard Kim and Phil as they began their presentation was raising the question of what, the presentation by Eastern Maine demonstrated that Northern Light Eastern Maine, I apologize to the Northern Light people, they have staff available to do some of this tracking work. And I specifically heard Kim and Philip ask about how people without dedicated staff do it. And while we don't have a whole lot of organizations on the call today, we have enough. So I think my question, it seems to me that everybody has at least a small amount of staff dedicated to the lung cancer screening program. I'm wondering sort of what are the minimal amounts of staff time that either people have experience, can do the tracking work, or that people think it would take to do the tracking. Because, you know, I think either this fully goes back to primary care to be responsible for tracking, or there is some staffing within the program that helps with that. And I'm just curious, what are the models in different places? Did that make sense, the question?
Yes, I think so. Thank you.
Okay.
So I think Cynthia and Andrea, not to call on you folks first, and then we'll go to faculty, but do you have some thoughts on that? Like minimal, you know, thinking of how maybe you've done it just starting out, or, you know, some advice that you could give?
As far as for engagement, the CT text giving a more consistent message was helpful. And then the PA can get to see more people afterwards. So we have her and the admin assistant, and then me for doing more of the ordering and follow-up. So that's truly not very many people, but I can't imagine doing it with less than that.
Okay, thank you.
You're welcome.
Turn it over to any of the other hospitals if they'd like to ask any or kind of respond to Dr. Corson's question. Again, I know we're a little less than usual today. Excuse me.
So this is Barb. So we have a lung nurse navigator and a community health worker that's following up with patients that are overdue with their scans. One thing that did help us, and now we're in transition, is a computer system for the data entry that automatically uploads. So I don't know if that might be helpful if you possibly can't get the resource on the admin side for the registry ports, because the other thing that the system will do is it will automatically produce the letters for you. So that might take a little bit of the stress off, or it did for us. Like, we were getting to the point where we couldn't manage it all. You know, prior to getting the system, we had our cancer registry folks trying to help keep up with the lung registry also, but it ended up just too many cases coming in too fast. So I would say, you know, maybe if you can't get extra staffing to support, I don't know if they would support a lung screening system. So.
And what's the name of your system, Barbara?
So our current system is through Siemens, and it's called Lung Navigator, or just Screening Navigator, but it's actually, it didn't take off with Siemens, so unfortunately they're not providing it as of December, so don't, I mean, they won't sell it to you, luckily, but so now we're looking at Lung GPS through like Philips, and we looked at, I believe what Northern Light had looked at also, which was LungView. Those were kind of our top two picks, and we haven't made a final decision yet, but I think we're leaning towards Lung GPS because it also has incidental nodule tracking, which we're interested in looking at, and then also Lung CADS, which allows the radiologist to compare a little bit more easily and gives a volumetric reading to the nodule, which we thought that our radiation oncologists and surgeons would appreciate too. So we're going to try to go bigger, but we'll see if we get it.
And Barbara, thank you for all that detail. Just to inject some reality Do you know ballpark what these systems will cost for an organization to use them?
Yeah, so the what we found is that if you're going for a system that is going to essentially capture the patients, help you produce the letters, and give an upload to the registry, that was around like between 24 to like 45. And I think Northern Lights looked at those systems too. It looked like that was about the range. And then the system that we're looking at to try to do the incidental screenings, incidental capture, also incidental nodules, and also the CAD, it's closer to like, I think 169, but we're trying to get Phillips to come down.
We're talking about thousands, right? I just want to make sure. Yeah.
Right.
Okay.
Right.
Just wanted to make sure.
Yeah, but that system's really robust. And then if you can module off where you don't have to get the CAD for the radiologist, and you don't have to have the incidental tracking. And then I think it's around the same price as like LungView and that type of thing.
Thank you. That's useful information.
Yeah, and I don't know if Northern Light, I know Amy and the team there had looked at some too. Is that about the quotes that you guys were seeing come through?
Hi, it's Amy. We've looked at several software vendors, I think probably 8 or 10. LungView was by far the cheapest we looked at, but it also didn't have all the extra features. The one we're looking at seriously now is Think Health, and it's about $80,000 a year.
Okay. Yeah, not cheap.
No. People may be cheaper than systems, but they still need systems to work with. That's the challenge.
Barb, this is Teresa from MainMed. I'm just curious, with this lung GPS that you're looking at, do you know if it loads the retrospective data? Is that something that's part of the package?
Yeah, and that was something that the radiologists were really interested in. It loads up the previous scan, and then it does a volumetric measurement. So it gives a volumetric reading of the nodule, which was helpful.
Yeah.
Yeah. I can send you, or I can send everybody, or I can, whoever's interested in the slides of the CAD readings, because it was pretty interesting.
Yeah, it was interesting. The results of, I think it was the Nelson trial, included that they looked at the volume rather than just the diameter of nodules. Yeah. And I asked Sean Novak, our thoracic radiologist friend, about that and whether Spectrum is using that kind of software, and they are not yet. So nobody in Maine that I'm aware of has software that will read volume. Sean thought there was potentially some advantage to that, although I think it's important for us to remember LungRads still uses diameter, not volume, to sort of identify where an individual is and what they ought to have done next. But the question of volume versus diameter might be one for us to all talk about at some point.
Mm-hmm. The only other thing I was thinking about for MDI is, I don't know if it's possible to partner. I think I was just pulling you guys up on a map. You're probably the closest site for thoracic surgery is Northern Light. Is that?
Yeah, that's correct.
Yeah, because I'm just thinking, like, if there's some type of partnership, like then, they have that great thoracic multidisciplinary team that could, I don't know, maybe you guys are already talking, but that's the first thing I was like, oh, who's their closest thoracic surgeon? Or a thoracic team, yeah.
Hi, it's Amy from Northern Light. And like Barb was saying, we have partnered with our other small hospitals because what we have found is that a lot of them were doing screening but had Excel sheets and didn't really have a dedicated navigator or data person to manage all of these patients. So what we've brought to them is the ability that they do the scans there. They're responsible for shared decision making. They've got to submit their own ACR data at this point, but we'll do all of the recall for them. And it's been really helpful getting some of our smaller facilities up and running. Pittsfield SVH wasn't doing scans, but between Waterville and here, there was nobody in between doing scans, and it's really taken off down there. Having the ability to do the scans and taking that data entry and recall away from them. And just like we do for our scans done here, we present those scans at our multidisciplinary conference. We report back the recommendations. And last time I calculated their data, 14 or 15% of their scans already had been RAD4s, and their third scan was a RAD4. So it certainly highlights the need to offer screening everywhere we can. I mean, people don't want to travel a half an hour for a 5-minute scan.
Right.
Oh, everyone, can you hear us now? Okay. I don't know, we're having a little technical, I think, piece with the sound because we have our light goes blue when we're live, and we were live, but yet we couldn't, for some reason you all couldn't hear us, so we're not sure what that is up with that. So, but we're on. So great. So Teresa, can you hear me? Just didn't know if you had some thoughts to share as well. Okay, perfect. Just wanted to give you an opportunity to talk about what you folks do and some thoughts for, Philip and Kim.
Well, a couple things I would recommend is a lot of talk about minimal staffing, and I think we tend to focus on that. But if you're thinking about building a lung screening program, no matter how small it starts, you have to plan for growth of the program. And then the other piece that's really important is consistent staffing. So I think a lot of programs fall short in those two areas. That's one of the big challenges. We've got one person who is an admin who follows up with the annual scans and calls the patient, reconfirms eligibility, and then schedules the patient. And then we've got a couple of nurses who work together to get the patients in for the baseline imaging. And then we have our multidisciplinary team conference on Friday mornings at Main Med from 8 to 9, and that's Matrix, and that's where I would present all of the RADS4 findings for review with our multidisciplinary team.
And then for follow-up, is that done with the two nurses that you mentioned before? Who does that communication up?
Yeah, for RADS 1 and 2, I let the patients know that if the scan is benign, then they won't be hearing from me, but they'll get a report through the mail or in my chart. And then if if there's a RADS 3 or 4 finding, then I would follow up with the patients directly and let them know that that with the follow-up is for RADS 3 is a 6-month follow-up, and then for RADS 4, I would let them know they'll be the imaging will be going to the multidisciplinary team conference, and I let them know that ahead of time during the consult that if they do fall into the RADS 4 category, that I prep them that that's the route we take, so that they have a pretty good working knowledge in terms of what possible findings could occur, and then how they'd be followed up on. So. Oh, and then the PCP is also informed as well. So I typically would follow up with PCPs for 3s and 4s just via in-basket, send them a note and let them know what's going on, and then go from there.
Great. Thank you so much. And you had said 2 big pieces. You had said plan for growth, Teresa, and I want to make sure I captured the other one. What was the first one that you had said?
Consistent staffing is really important.
That was it. Yeah. Thank you. All right, just doing a time check. We have about 1 more minute, and then I'll try to go through some of the notes and give some feedback on what we have so far. So just giving anyone else an opportunity to give some thoughts. Philip or Kim, please feel free to unmute and ask any more questions of the group, and we're happy to all, try to answer those as well.
Thank you all. I think we've gotten some pretty good ideas. I've taken quite a few notes here, some things that might help us out in the future. There's no kind of, things to play around with and work on, but we have some good ideas and some good leads. So thank you.
Perfect, thank you. And again, I will loop back with those hospitals that aren't with us today and get some processes and just set up some quick calls with them and get that information back to you as well. And please note, everyone in general, if there's anything that they do differently or some ideas or thoughts that they might have, I will put those in the notes for everyone else as well. So you'll all get that feedback as well. And per usual, if you all have any resources or things that you use or have used to guide as you develop this process around this, RADS 3 and 4 follow-up really is what we're talking about, and sending that along, please send those along for notes as well. Okay, great. So I'm just going to do a quick recap then in regards to notes. Just again, I have taken a lot of them, so I'm just going to